Okay.
Well, good morning, everyone, and welcome to the Maryland Insurance Administration's Life and Health Industry Meeting. I'm Kathleen Borain. I serve as the Maryland Insurance Commissioner, and I am very much looking forward to an informative discussion today. The purpose of our industry meeting is to discuss 2022 legislation, regulations, operational issues, and any other matters of concern to the industry. We thank everyone who sent in questions and agenda recommendations in advance. Before we get to our agenda, I'd just like to take the opportunity to introduce my colleagues from the Maryland Insurance Administration that will be speaking today. First, Associate Commissioner for Life and Health, David Cooney.
Good morning.
Mary Quay, our Associate Commissioner for Market Regulation and Professional Licensing.
Good morning.
Joy Hatchett, the Associate Commissioner for Consumer Education and Advocacy.
Good morning.
Van Dorsey, our Principal Counsel.
Good morning.
And Adam Zimmerman, Senior Actuary.
Good morning.
And you've met Craig I, who is our, Director of Communications.
Hello and welcome.
So as indicated, this public industry meeting is being recorded today, and it will be posted on the Maryland Insurance Administration's website. We do have a robust agenda, but as time and technology allow, we will want to hear from you. If you would like to speak, please let us know using the chat feature that you would like to speak, and we'll, if we're able to, with time, bring you over to make comments. To ensure excellent sound quality and video quality throughout the meeting, we ask that you please stay on mute with your video off unless you're speaking. And now I'm going to turn it over to David Cooney, who will run our agenda today.
Thank you, Commissioner, and good morning once again, everyone. So the first item on our agenda is a brief recap of the 2022 legislative session. There were many life and health bills impacting the industry that passed this year, but there were a few in particular where we want to highlight certain aspects or implementation issues that we identified or are anticipating may arise over the next few months. And the first bill is Senate Bill 823, which is related to pharmacy services, administrative organizations, and pharmacy benefit managers. As background, House Bill 978 from the 2020 legislative session had established a new regulatory framework for PSAOs under Title 15, Subtitle 20 of the insurance article. The legislative intent was to subject PSAOs to the same level of regulatory oversight that currently exists for PBMs. One of the biggest challenges, however, that we faced in implementing the PSAO subtitle was the new form filing requirements for PSAOs. Section 15-2010 of the insurance article required PSAOs to file with the MIA all contracts with independent pharmacies, as well as all contracts that PSAO entered into with PBMs on behalf of independent pharmacies. The requirement for PSAOs to file their contracts with PBMs caused really a logistical nightmare for both the PSAOs and the MIA, because it's the PBMs rather than the PSAOs who actually draft those contracts and control the terms that are offered. So this made it impossible for the PSAOs to file contract templates with the MIA, which is our standard way of handling form filings. And instead, the PSAOs had to file every single contract they intended to enter with any PBM before the contract could become effective. And then if the MIA needed to require any revisions to those initial filings, this presented further challenges because the PSAO essentially had to act as a go-between and attempt to get the PBM to make the requested revisions instead of the MIA directly requiring the PBM to do so. So Senate Bill 823 from 2022 was intended to address this issue and also make a few other technical revisions to the PSAO subtitle to streamline the regulatory oversight of PSAOs. The bill clarified that a PSAO that has not entered into any agreements or contracts with an independent pharmacy in Maryland is not required to register with the commissioner, even if that PSAO has entered into an agreement with the PBM. The bill also clarified that certain required disclosures and documents from the PSAO to the independent pharmacies can be provided electronically. Most significantly, though, the bill repealed the requirement for PSAOs to file their contracts with PBMs, and it expanded the requirements in 15-16-28 of the insurance article to now require PBMs to file their contracts between PSAOs and PBMs with the MIA on an informational basis. So effective October 1st of this year, PSAOs will no longer be required to file these contracts, but PBMs must begin filing them at least 30 days before the contracts are to become effective. It's important to note, though, that PSAOs are required to continue to file their own contracts they intend to enter into with independent pharmacies. The original 2020 bill had also required the MIA to promulgate regulations to implement the new PSAO subtitle. And different drafts of the regulations had been posted to the MIA website, and they were formally proposed on December 17th, 2021. However, once the MIA became aware of Senate Bill 823 in 2022, we delayed finalizing those regulations until Senate Bill 823 was enacted so that we can incorporate the new changes as well. We now anticipate publishing those changes as a reproposal of the regulations that were initially proposed in December, and they're currently in the final stages of our internal routing and approval process, and we anticipate issuing those soon. Until those regulations are effective, the MIA will continue to follow the review process outlined in Bulletin 21-07 for contracts between PSAOs and independent pharmacies. And the MIA will continue to exercise enforcement discretion described in that bulletin for PSAOs who make good faith efforts to comply with the statute. The next bill we want to discuss is Senate Bill 164, which is related to insurance annuities, non-forfeiture interest rate requirements. So Senate Bill 164 made a very straightforward change to Section 16504 of the insurance article. Specifically, the minimum interest rate used to determine the non-forfeiture amounts for annuity contracts was changed from 1% to 0.15%. This change conformed Maryland law to a recent change under NAIC Model Law number 805. While these changes do not require amendments to annuity contracts filed with the MIA, if carriers do wish to start using the lower interest rates in contracts issued on or after October 1st, 2022, filings will be required. Those filings may either be submitted through the Interstate Compact or directly to the MIA. If a carrier chooses to file a revised non-forfeiture rate filing with a compact, we ask carriers to please refer to the new resource on annuity non-forfeiture that was described in the Compact's weekly tip dated November 4th, 2021, which clarified that compact product filings must follow each state's minimum non-forfeiture rate law in effect at the time a product is issued. On the other hand, if a carrier chooses to file non-forfeiture rate changes directly with the MIA, we'll apply the same filing requirements that are applicable to non-forfeiture rate and or mortality rate change filings for life insurance. These filings should be submitted through SURF, and the carrier will need to submit a revised actuarial memorandum demonstrating non-forfeiture compliance pursuant to sections 16504, 506, and 508, along with a filing fee of $125 per filing and revised policy pages and or scheduled pages that will maintain the original policy's form number. The filing description must include information about the previously approved contract forms, including the form number, approval date, and SURF tracking number. Now, moving on to Senate Bill 180, this was our conformity bill with the Federal No Surprises Act, or the NSA. Senate Bill 180 was passed as an emergency measure effective from the date of enactment, and it was signed by the governor on April 21st. The bill grants the commissioner broad authority to enforce all the applicable requirements of the Consolidated Appropriations Act of 2021, and in particular, the No Surprises Act against carriers in Maryland. As a reminder, the NSA does not preempt state standards that are more consumer protective. So it is important for carriers to consider the requirements of existing state laws that address the same or related circumstances as those covered by the NSA. Excuse me. As a reminder, for example, Maryland law includes balanced billing protections for certain types of services and providers, and specifically establishes that the required rate of payment for certain out-of-network services, including all covered services under an HMO contract, services provided under PPO and EPO plans by on-call and hospital-based physicians who accept assignment of benefits, and claims for hospital services under all plans. This means the new federal independent dispute resolution process would only apply in Maryland for purposes of determining the out-of-network rate for claims not subject to these laws. And in this situation, the MIA will simply enforce the outcome of the federal independent dispute resolution process. Additionally, there are distinctions between the Maryland-specific provider directory requirements under 15112 of the insurance article and the corresponding provisions under the NSA. We will be enforcing both, and if there are differing requirements, such as conflicting timeframes, we will enforce whichever is more stringent. As additional federal guidance is released and implementation issues start to become clearer, we do intend to expressly incorporate the No Surprises Act provisions into Maryland law during future legislative sessions in order to provide further clarity about the applicability and interpretation of each requirement. Since we initially lacked the authority to enforce most of the NSA provisions at the state level, we had been in preliminary discussions with the federal government to enter into a collaborative enforcement agreement with CMS. However, once Senate Bill 180 was enacted, we advised CMS that we determined a collaborative enforcement agreement was no longer necessary, and CMS posted a revised enforcement letter for Maryland on their website on May 18th, 2022. Notably, the CMS letter confirms that Maryland has authority and intends to enforce specific provisions of the Consolidated Appropriations Act, with MIA enforcing the requirements against carriers and HEAU of the Office of the Attorney General enforcing requirements against providers, including facilities and providers of air ambulance services. The letter also clarifies that CMS determined that the Maryland external review process currently has the capability to address adverse determinations related to the surprise billing protections of the No Surprises Act. And we want to remind carriers about the definitions and examples for external review that were included in the October 7th, 2021 IFR titled Requirements Related to Balance Billing, Part 2. We will be using these definitions when we investigate and adjudicate complaints. The only areas where HHS will retain direct enforcement authority over carriers is for the new reporting requirements to HHS that are related to agent and broker compensation, air ambulance services, pharmacy benefits and drug costs, and compliance with the prohibition on gag clauses on price and quality information. Finally, I want to remind carriers about the federal FAQ Part 49 that was issued on August 20th, 2021, and which explained that the federal government was exercising discretion to defer the enforcement effective date for some of the requirements under the CAA and related federal laws. Some of the provisions with deferred effective dates are contingent on the release of federal rules that still have not been promulgated to date. However, there are a few provisions where the deferral period will be expiring within the next 12 months. Specifically, enforcement of the requirement under the transparency and coverage rule to post machine-readable files related to in and out of network prices will go into effect on July 1st, in just a couple of weeks. Enforcement of the price comparison tool under the CAA will go into effect on January 1st, 2023. And the HHS reporting requirements for pharmacy benefits and drug costs will be enforced starting on December 27th, 2022. And with that, I think I'll be turning it over to Adam Zimmerman to discuss House Bill 247.
Thank you, David. I will be discussing House Bill 247 from the 2022 legislative session, which is insurance, Medicare supplement policies, open enrollment period following birthday. So starting July 1st, 2023, Medicare supplement members are going to have an annual open enrollment period, which will allow them to switch to a plan with equal or lesser benefits. The open enrollment period will be the 30 days following the birthday of a Medicare supplement member, and the open enrollment period will allow members to switch to any carrier they wish without having to go through underwriting. The MIA is currently in the process of finalizing a matrix for publication via regulation, which shows the plans a member is able to switch from each of the possible current Medicare supplement plans. 3 other states have implemented the same birthday rule and published matrices. Those states are Oregon, Nevada, and Idaho. And all of the matrices are the same, with the exception of high deductible Plan J. The Oregon and Nevada matrix states that a member in high deductible Plan J can only switch to high deductible Plan F. The Idaho matrix states that a high deductible Plan J member can switch to either high deductible Plan G or high deductible Plan F. The MIA agrees with the Idaho matrix that high deductible Plan G is also a lesser benefit than high deductible Plan J, and intends to adopt the Idaho matrix, but welcomes any industry feedback. Additionally, there are several plans, which include Plan A, Plan High Deductible G, Plan K, and Plan N that have no plan that is considered lesser, and members in these plans will only be able to switch to the same plan from another carrier. If you're interested in viewing the proposed matrix, if you Google something along the lines of Idaho Medicare Supplement Birthday Rule Matrix, this will bring you to the Idaho Department of Insurance's website, and that has the matrix published outlining all the plans that members are able to switch to. And this is the matrix that the MIA is planning to adopt. And that is the wrap up of House Bill 247. So with that, I'll turn it back to the Commissioner, who will discuss Senate Bill 207.
Okay, thank you, Adam. So Senate Bill 207, the cybersecurity bill. So before I start, let me express my appreciation to industry and to other stakeholders, many of whom are on this call today, for a robust and thorough process that I think in the end got us to a really good place. So I was very, very pleased that we were able to get this legislation, which I think is really critically important for the protection of Maryland consumers, for letting us get this through this year. So Senate Bill 207 adds Title 33 to the insurance article to establish cybersecurity standards and reporting requirements for the licensees specified in the definition of carrier. Section 33-103 of the law requires a comprehensive written information security program to protect non-public information and a written incident response plan for cybersecurity events. The law includes specific requirements for the security program and the incident response plan. The law takes effect on October 1st, 2022. Carriers have until October 1st, 2023 to implement 33103. Carriers have an additional year to require compliance by vendors pursuant to 33103H. Implementation is delayed by an additional year for carriers that have fewer than 25 employees and are below the threshold set in the uncodified text of the bill for gross annual revenue, total assets, or annual direct written premium. On or before April 15th of each year, each carrier is required to submit a written statement certifying that the carrier is in compliance with the requirements of 33103. Details of the information required to be in the notice are specified in the statute. Carriers that are not domiciled in Maryland are exempt from the filing requirement if the carrier is domiciled in another state or U.S. jurisdiction that has adopted a law or regulation that is substantially similar and files the required certification with its domestic regulator, or is within an insurance holding company system and has implemented an information security system that has been approved and is maintained by another carrier within that same insurance holding company system that meets the requirements for an exemption. Following a cybersecurity event, a carrier will have to notify the commissioner as promptly as possible, but no more than 3 business days after the termination that an event has occurred. A cybersecurity event must be reported if Maryland is the carrier's state of domicile and the event has a reasonable likelihood of harming a consumer residing in the state or harming any material part of the carrier's normal operations. A carrier that is not domiciled in the state must report a cybersecurity event if the carrier reasonably believes that the non-public information involved is of 250 or more consumers residing in the state, and either notice is required to a government body, self-regulatory agency, or other supervisory body under state or federal law, or there is a reasonable likelihood of material harm to a consumer residing in the state or to a material part of the carrier's normal operations. The information required by the notice is specified in the statute. The MIA will be issuing a bulletin with additional information on the reporting requirements Because these are detailed, we will likely pre-publish this bulletin, or I should say, post this bulletin for comment before it is finally issued. Okay, and with that, let me turn the agenda back to David.
Thank you, Commissioner. So next, I want to spend a little bit of time going over some updates related to network adequacy, specifically with respect to the annual filings and the revised regulations. As a reminder, the 2022 annual network access plan filings for health benefit plans are due in just over 2 weeks on Friday, July 1st. As explained in Bulletin 22-05, which was issued on May 12th, and a change from the past several years, filings will be required to be submitted through SURF in 2022. MIA staff worked with the NAIC SURF team to ensure that the SURF system would be able to accommodate these filings, and we created a new SURF filing type and state-specific type of insurance with detailed submission requirements for network access plans. To promote greater uniformity in submission formats across carriers, optional templates were also developed for the required supporting documentation that must be submitted with the access plans. While the templates are optional, we are highly encouraging carriers to use them when submitting their documentation because most of the information requested in the templates is information that will ultimately be needed to complete our reviews, even if the carrier chooses to submit the materials in a different format. We also posted corresponding instructions with additional details to the MIA website under the network adequacy page. This includes revised geographic classifications for certain urban, rural, and suburban zip codes, or ZICTAs, based on updated population information that was provided by the Maryland Department of Planning. We also want to make sure carriers are aware that filings that are not submitted in accordance with the new instructions will be rejected, and the carrier will be required to resubmit the filing through SURF in the required manner. We are hopeful that the new instructions and submission method for 2022 will make the review process more efficient and reduce a lot of the back and forth correspondence that has been necessary in years past. Now, for next year, it is anticipated that the revisions to the network adequacy regulations will be in place to ensure even greater uniformity when the 2023 access plans are filed. We've been working hard over the past couple months to finalize the next draft of the network adequacy regulations, and we anticipate posting a draft version to the MIA website for public comment in early July. We will follow up with a public meeting in early August to discuss the draft with stakeholders, and as usual, we'll accept both written and oral comments. We then intend to move forward with the formal proposal as soon as possible after that, but this will depend on the volume of comments we receive and the extent of further revisions that we determine are necessary based on those comments. Our goal, however, is to have the regulations finalized before the end of the year. As a brief high-level primer, the next draft incorporates many of the comments we received in the last public draft, and it will include enhanced reporting requirements from carriers on out-of-network claims data, complaints about provider accessibility, and carrier efforts to enhance network adequacy to meet the needs of consumers. The draft will also include new proposals for how telehealth is taken into account when measuring network adequacy. And this will include data requirements as well as consideration of the impact on the standards for travel distance and appointment wait times. As industry is aware, the Preserve Telehealth Access Act of 2021 required the MIA to contribute to the comprehensive study on telehealth that is currently being conducted by the Maryland Healthcare Commission, and to also for the MIA to consider the requirements of the Act when revising our network adequacy regulations. As part of our research for that study, we initiated a data call on May 31st from carriers offering health benefit plans to gather certain information on telehealth benefits offered in plans issued in Maryland. Just a reminder that those responses are coming up due at the end of the month, and we're looking forward to receiving the requested information. The final telehealth report from MHCC is required to include a review of the appropriateness of telehealth to satisfy network adequacy standards. And the MIA's position on this issue will be reflected in the final telehealth proposal that will be included in the revised regulations. And that wraps it up for network adequacy for now. And I can turn it over to Mary to discuss mental health parity reporting.
Thank you, David. It took me a minute to get my cursor in the right place. So as you are all probably aware, at least if you're on the health side, Section 15, 144 of the insurance article was passed in 2020 to require carriers to file reports of their analysis of compliance with the Mental Health Parity and Addiction Equity Act with regard to non-quantitative treatment limitations, or NQTLs. Carriers were required to file reports on or before March 1st, 2022. The MIA adopted regulations and a requirement for supplemental data reports. The supplemental data reports were due on April 1st, 2022. The statute specifies that if the commissioner finds that a carrier failed to submit a complete report, the commissioner may impose a penalty and is required to consider the late filing of a report to be a serious violation with a significantly deleterious effect on the public. The MIA received reports for 208 health plans. Several carriers missed the March 1st deadline, and the MIA is preparing orders for failing to file the reports timely. One order has already been issued. The additional data supplements were received on time from most carriers. The MIA has started an in-depth review of the reports. A contractual employee has been added to focus on reviewing the reports full-time. It appears that most of the reports are seriously deficient and fail to adequately document an analysis of whether the NQTL complies with the requirements of MIA. A letter will be sent following the initial review of a plan for a carrier, outlining the deficiencies in the report. The carrier will be asked to address the deficiencies and correct all of its filed plans that have the same analysis as in the plan that was reviewed. Orders with penalties for failure to file a complete report are likely to be the next step. There will need to be significant follow-up by the MIA and additional analysis submitted by carriers in order to determine whether there are substantive parity violations. This is consistent with the experiences of other regulators, including other states and the Federal Department of Labor, who have said that reports have been insufficient to demonstrate compliance and that multiple rounds of additional follow-up by the regulator have been necessary to obtain complete reports. And next, I will talk about pharmacist reimbursement. And House Bill 1219 and Senate Bill 661 require the MIA to establish a work group with representatives of pharmacists, carriers, and managed care organizations to identify options and requirements necessary to reimburse pharmacists who provide medical services within their scope of practice. The work group's first meeting will be on June 27th at 10 o'clock and will be virtual. For the first meeting, the focus is to identify the barriers that exist, both for MCOs and for carriers. Subsequent meetings will delve into the reasons for specific barriers and discuss proposed solutions. The MIA is required to submit its findings and recommendations by the end of the year. And then another work group I will be discussing is from Senate Bill 460, which was introduced during the 2022 session by Senator Augustine to create a consumer health access program for mental health and addiction care. Delegate Lewis sponsored House Bill 517, the corresponding bill on the House side. Delegate Pena Melnick, Vice Chair of the House Health and Government Operations Committee, asked the Insurance Administration to convene and lead a working group to address concerns raised about some aspects of the bills and to make recommendations that can be implemented in a new bill to be introduced in 2023. The MIA has asked Senator Augustine, Delegate Lewis, representatives of carriers, and mental health advocates to participate in the working group. A core purpose of the proposed program, SHAP, is to assist people in navigating the healthcare system to access care, and then secure payment for the services from their healthcare plan or program. There is broad support for the establishment of a program to assist with navigating the system, to find the right treatment program, and to coordinate coverage and payment for the treatment from any healthcare plan or program available to the patient. However, there were concerns raised about other aspects of the bill. The first meeting of the working group will be on Friday, June 17th at 10 a.m. A notice and agenda are posted on the MIA's website. The notice lays out a preliminary list of issues that the working group will address, including the scope of activities, privacy, and the nature of the hub, its budget, and oversight. The agenda includes some time for public comments, time permitting. And so I am turning it over to Adam Zimmerman to discuss the COVID impact on rate filings.
Thank you, Mary. So as Mary pointed out, I'll be talking about the COVID impact on rate filings. So as the rate filings for 2023 are beginning to come in, COVID experience could potentially play a big role in the rate development. And so in order to assist in the rate review process and expedite the rate review process, we would ask the carriers to please provide the following to the best of their ability when filing for 2023 rates. Every rate filing should include historic experience, including both 2020 and 2021 experience, even if the carrier is intending to use the 2019 experience to set rates for 2023. The filing should split out the COVID experience for both 2020 and 2021 between non-COVID experience and COVID experience, and if possible, split the COVID experience into the components of testing, treatment, and vaccination costs. If 2020 or 2021 experience is used as a starting point for the rating, then an attempt should be made by the carrier to quantify expected differences in testing, treatment, and vaccinations between the experience period data and the rating period. The general expectation from the MIA is that future treatment costs are going to be lower in 2023 and beyond than they were in 2020 or 2021. And vaccine and testing costs may be higher or lower depending on the details of the carrier's experience and assumptions. And finally, in 2020, there was a lot of deferred care due to the shutdowns and medical procedures being canceled. So the carrier should make an attempt as to whether any of the non-COVID care that was deferred in 2020 was delayed until 2021, rather than being canceled altogether, by analyzing monthly 2021 non-COVID experience for any bulges or outliers in claims. And so with that being said, I'll turn it back over to David, who will outline the annuity suitability regulations.
Thank you, Adam. Yeah, so as Adam said, I just want to remind carriers about those recently finalized regulations that on April 8th, 2022, the Insurance Commissioner repealed existing regulations 01 through 11 and adopted new regulations 01 through 13 under COMAR 310912 suitability, and annuity transactions. These are consumer protective regulations that require producers to act in the best interest of the consumer when making a recommendation of an annuity. In finalizing these regulations, Maryland joined 24 other jurisdictions who had already adopted the NAIC annuity suitability model regulation number 275. And currently 4 additional jurisdictions are pending adoption. Under the new regulations, to comply with the best interest obligation, a producer or an insurer in the case of direct sales must satisfy 4 obligations, and those related to care, disclosure, conflict of interest, and documentation. I want to highlight regulations 11, 12, and 13 in particular. These regulations provide the required forms that producers must use to satisfy the disclosure obligation in Regulation 04E1 and the documentation obligations in Regulation 04G. As industry may already be aware, the NAIC Suitability Working Group continues to work on an FAQ document that will be used as an implementation guide for states. The last call was on May 26th, and we continue to monitor these calls. It is important to stress that all recommendations made by a producer or insurer to purchase, exchange, or replace an annuity product must comply with the new best interest standard of conduct. Although the standards were finalized on April 8th, they do not go into effect until October 8th, 2022, in order to give insurers and producers sufficient time to comply with the new requirements. And finally, the last topic we want to discuss on our prepared agenda is the upcoming end of the federal public health emergency. So prior to the recent kind of mini surge in COVID cases, the general consensus was that the federal public health emergency would be allowed to expire on July 15th. However, the Biden administration had previously committed to giving states 60-day notice in advance of the end of the PHE. And since that notice has not been provided, it looks like the public health emergency will be extended until at least mid-October. Even though this gives everyone a bit more breathing room to work through all the implications of the termination of the public health emergency, it's very important for carriers to start preparing now for those impacts. In Maryland, one of the issues we ran into toward the latter portion of the PHE after the state level emergency declaration was rescinded was that the commissioner was not authorized to activate any of her emergency powers based on the existence of the public health emergency issued by HHS or the national emergency that had been issued by the president. House Bill 536 was enacted this year as an emergency measure to address this issue, and revisions to our own emergency powers regulations to conform to the statutory changes are currently moving through our internal process, and we will be proposing those in the changes in the near future. House Bill 536 also included uncodified text to address one particularly challenging issue that impacts Medicare supplement coverage, which was an unintended consequence of one of the concessions made by the federal government during the PHE. Specifically, the uncodified text in House Bill 536 requires all Medicare supplement carriers to provide a 63-day guarantee issue period for certain individuals to enroll in a Medicare supplement plan without underwriting following termination of their Medicaid coverage. This applies to individuals who, through no fault of their own, forfeited their 6-month open enrollment period for a Medicare supplement plan following their initial enrollment in Medicare Part B. This problem was caused by the fact that during the PHE, CMS prohibited state Medicaid programs from terminating Medicaid enrollees when those enrollees became eligible for Medicare. Since a Medicare supplement plan cannot be issued to an individual who is covered under Medicaid, impacted Medicaid enrollees would not be able to apply for a Medicare supplement policy until their Medicaid coverage terminated. Once the PHE extended beyond 6 months, more and more Medicaid enrollees had exhausted their 6-month open enrollment period while they remained covered under Medicaid. If any of these enrollees had pre-existing health conditions, they would not be able to pass underwriting and would therefore be unable to purchase Medicare supplement coverage once they were finally able to apply. Although a solution at the federal level is necessary to address this issue nationally, Maryland consumers will now be protected due to House Bill 536. It is very important for all Medicare supplement carriers to be aware of this requirement and be prepared to process the enrollment of these eligible individuals into any policy without underwriting when the time comes. The MIA will issue a bulletin to remind carriers of this requirement closer to the expiration of the public health emergency. In addition to this issue, it's also important that all health carriers consider other coverage implications that are related to any federal requirements that were tied to the existence of a national or public health emergency. For example, at this time, the requirement to cover testing for COVID-19 without cost sharing is contingent on the public health emergency. Subject to the particular provisions of each contract, when the PHE expires, carriers will be permitted to apply cost sharing to these tests. COVID-19 vaccinations, on the other hand, must continue to be covered without cost sharing even after the PHE ends. This may result in consumer confusion if folks are suddenly charged copays for the COVID tests mid-plan year. Another issue to consider is a potential impact of the end of the PHE on enrollee access to telehealth services from network providers. The temporary relaxation of HIPAA privacy requirements related to telehealth during the PHE allowed the use of commonly available applications like Zoom and FaceTime to deliver telehealth. It is unknown what the impact will be when the Office of Civil Rights resumes enforcement of the privacy requirements after the PHE, but at least some minor disruptions in care may be anticipated. Also, the extension of election periods and notice deadlines for COBRA and certain other group health plan provisions will end 60 days after the termination of the COVID-19 national emergency, and carriers must be prepared for this. Our request is that companies continue to update us with their plans for any mandatory or voluntary accommodations related to COVID-19 so that we have accurate information that we can provide to consumers. For example, we would like to know if any carriers intend to continue to waive cost sharing for COVID-19 tests through the end of the year, even if the PHE expires before then. And as always, we appreciate your cooperation. With that, I think I'm turning it over to Craig to see whether we have any pre-registered speakers who would like to speak, or perhaps the commissioner.
No, that's okay. Craig can comment on, I don't think we have any, right, Craig?
We do not at this point, yeah. And if anyone would like to ask a question, please put your question in the chat and we will call on you.
I have a question for you, for the industry, and that is one of the things that I heard very recently was a concern that hospitals are, with perhaps more frequency, keeping folks in the hospital for a day or two longer than would otherwise be necessary because of supply chain issues with durable medical equipment that would be necessary in order for the individual to be discharged home effectively. If people want to speak to that now, that's great. But if that is accurate, it would be helpful for you to let us know that that is going on. I know that there are some discussions that are happening at the Department of Aging and elsewhere about expanding a recycling program, if you will, for durable medical equipment. But in the course of those conversations, this issue arose. One of the hospitals was indicating that they've been seeing some increase in this issue. So if you're hearing it as insurers, we would be interested in learning that from you guys. If you could just let David and Mary know what's going on, I'd appreciate it. Craig, do you want to just bring Matt over so he can ask his question?
Yes, he could just unmute himself and speak.
Okay.
So.
Good morning, Commissioner Brain. Good morning, everybody. Thank you so much for doing these meetings again. It's really good to see everybody. I had sent this over to Craig before, but it is a question that I've been getting from the life companies, and I know 2023 is still a long way away, but does the MIA have any plans for next year to have the A&H eligible group law mirror the group life law now? And is there any plans for legislation adopting the NAIC model for discretionary groups?
So what I would say, Matt, is that, as you know, we cannot discuss any potential, future legislation. And obviously this coming year, that's particularly true because there will be a change in the administration. So I can't really say anything about, whether this is in anybody's thought process that this is something that the MIA is willing, is looking to do. However, to the extent that industry is interested in proposing legislation or looking at the NAIC model for discretionary groups, we're happy to have a conversation about that. If you want to reach out to David and Mary and Van and get that organized, and Corey, we'll be happy to have that chat.
Thank you very much. I'll reach out. Thanks.
So we have one more question in the chat. Glenn Arrington.
Just
Yes,
Yeah.
yes, this is Glenn Arrington. Craig, I think I sent actually the email to you that as an agent producer, sometimes it's difficult to get these certificates of loss of coverage. I've been doing this 28 years, and according to Craig's findings of my question, that the HMO carriers are only required to directly mail out the losses of certificate of coverage of loss. And with people having to enroll in the Maryland exchanges and the individual private plans, it seems like sometimes it's difficult to get those certificates of coverage. And in years past, I used to always say, well, the carriers are required to mail that out to the recipient that has lost coverage. However, Craig corrected me and said only the HMOs are required by regulation to be mailed out. So if they have a PPO or an EPO or I guess a point of service product, it's not a requirement for them to get it. And what the carriers claim is that, well, the former employee can go online and get it, or they can ask for it and call customer service. But we as brokers would love to have access to that so we can get these people enrolled and get those losses of coverage uploaded, because that always seems to be the delay. And these people that are trying to get coverage, and we have to get that document and load it in the Maryland Health Connection, or we have to send it to the carrier to show why they're enrolling during a special open enrollment. So I don't know if we can propose legislation for that to get Maryland carriers to make sure they mail them out, but it would certainly make life a lot easier.
Well, thank you for those comments. I mean, obviously, I'm not sure what the appropriate solution is, but to the extent that it is a challenge for folks to get that information, we should have a conversation about ways to make it easier to get that information. So thank you. And we will put that on our life and health agenda.
Thank you.
Sure. Any other questions or comments?
Not seeing anyone else in the chat.
All right, going once, going twice. All right, obviously, David and the team knocked it out of the park with clarity. Oh, I see someone who just unmuted. Oh, okay. All right, well, with that, then let me thank everyone, certainly on my team, who put this extremely informative session together. Thanks for members of the industry and other stakeholders for your questions and your comments that helped us to build the agenda. And if there's nothing else, then I think we're going to go ahead and go offline and wish everybody a happy Tuesday.